Hey, I'm Allison Hare, and welcome to Little Left of Center, the podcast that interviews culture changers that are reshaping our world and breaking new ground. On today's episode, I got to sit down with Dr. Brad Bootstaylor, the award-winning, double-board certified OBGYN and perinatologist of C-Baby practice in Atlanta. With C-section rates skyrocketing and a higher focus on reducing maternal mortality, Dr. Bootstaylor has been a beacon of hope for mothers and families who want a better birth experience. He gives great advice on advocating for yourself as a mother and owning your own power as someone bringing life to the world. He has been life-changing for me as he supported the birth of my second child. Let's take a listen. Hello, I'm so excited to be sitting across from you. I cannot believe that I have you here. And I'm here with Dr. Bradford Bootstaylor, the one and only. Dr. Bootstaylor has been incredibly healing in my life. And I've had some really awful experience with doctors. And I've had a couple of experiences with doctors that have changed everything for me and has made me more of an advocate from a patient perspective of how do we, as people who need healthcare, find the best people and understand and advocate for our best healthcare. So I'm so grateful that you're here today. I know your schedule is so busy. It's taken us months to get us here. So I thank you so much for being here. But
thank you.
Yes, please tell me about yourself.
Well, one, I'm happy to be here. Thank you. Miss Hare, Allison, if I can call you that. Where do I begin? I don't know.
I think being double boarded is kind of a big deal.
I am double boarded, one in obstetrics and gynecology, and that second board is maternal fetal medicine. Some people call it perinatology, but it's better known as high risk obstetrics. So I did have the, determination to, one, get through an OBGYN residency. And then I coupled that with a fellowship in maternal fetal medicine, and I'm boarded in those specialties.
And nobody does that. That's not common, is it?
Well, what's not common is to take that board certification and actually support mothers through the laboring process, which as a maternal fetal medicine specialist, you understand the science behind why certain things occur and why certain recommendations are made. And you understand the clinical application of that science. Usually as a perinatologist, you end up providing roadmaps and
it's more
guidelines.
Advising, right.
Right. An advisory role, more so than someone who's actually walking side by side with a patient and or an obstetrician. So what's unusual actually is to be able to actually do the clinical support as well.
So what made you want to do that?
Good question.
Why in God's green earth would you do that?
Why would I subject myself to having a 9-to-5 job to now having a 24/7 obligation?
Yes.
It comes probably from the duration of doing this, in all fairness. Somebody asked me Sunday, if I can sidetrack, when did you do your first delivery? And I told them I did my first delivery as a medical student in 1987. During that time period, the things that I now support were very commonplace back then. And it was based on science, but also in that era, there was a lot of, quote unquote, I call them old timers, who did a lot of clinical obstetrics. So you had the clinical background for managing and caring for mothers. Back then, that was the norm for things such as vaginal twin deliveries, vaginal birth after cesarean, et cetera, et cetera. And so I come from that background. I added the maternal fetal medicine fellowship to kind of fine tune my appreciation of it from a scientific perspective. How did I get to this point in time is after giving advice for about 15, 17 years as a consultant, I was able to partner with some midwives and had the ability to see how if you can support certain choices, you can make for more empowering birth experiences. And so it was bringing that clinical background from when I was a resident coupled with my maternal fetal medicine background, and then now working with midwives and realizing that those options were no longer supported. And I was able to do that really seamlessly.
Yeah. And I find that it's an interesting time now because when you are an expectant mother,
right,
you are hoping and trusting that you've got the greatest care, right?
Right.
And your hope is that, and as it should be, your hope is that your birth will be uneventful. And it's coming out now where there's more of a focus on maternal health,
right,
specifically on maternal mortality,
right,
which there's been a law passed in December for HB 1318
mm-hmm.
on providing more help with that too.
Right.
But the C-section rate still keeps rising, and
Right.
it's such a concern. And you come from a place of supporting the mother,
Right.
and helping the mother. And I'm curious to see how there is a rise in C-sections, more surgical births,
Right.
but you are positioning a choice.
Right.
And the way I came to you is that with my son who's 6, I was pressured into a C-section. I had too much amniotic fluid. They thought I should induce
Right. Right.
2 weeks early.
Right.
And there were a lot of complications with it.
Right.
I remember just a horrible feeling of having that choice and that power taken away from me
Right.
when the doctor kept pushing, and I was scared. I didn't know that I had other options.
Right.
And I was crying and full of drugs and Pitocin and,
Right.
the epidural
Right.
and all of
Right.
that stuff.
Right.
And then being pushed into a C-section and given maybe not all the information. I think it was purposeful, now knowing what I know.
Right.
And my son was born. He was in the NICU for 9 days. He was simply undercooked.
Right.
They
Right.
induced him 2 weeks early.
Right.
And he never latched for breastfeeding. So I pumped exclusively for
Right.
8.5 months.
Right. Wow.
So we could have that. So it's just,
Yeah.
I remember when I got pregnant the second time, and I had 4 doctors tell me I absolutely had to have a C-section with the second one,
Right.
with the risk of uterine rupture, and that I
Right.
would have to have it earlier, like 36, 37 weeks.
Right. Wow.
And I remember thinking, I want a different experience. And somebody told me, you need to talk to Dr. Bootstaylor. And I remember sitting down with you and you had my medical records and you said, we believe in shared decision making here.
Right.
And I'm like, what is that? Do I need a C-section or not? And
I recall that. It's like, well, you have choices based on what I see before me.
right. And so you were reviewing my medical records and
Yeah.
you said, I see where the incisions were. I know you had a myomectomy,
Right.
which is a removal of a fibroid.
Right.
And he's like, I'm looking at it and your body can stand the trial of labor if you
Right.
want.
Right.
But do I have to have a C-section? And you're like, do you want one? And I was like, this is not how...
Yeah. Yeah.
This is not
kinda
how
puts
I'm
you in the
used to.
driver's seat a little bit. Yeah.
Right. But at first
Yeah.
I thought, wait a minute. Is he a quack?
Right.
Why isn't he telling me what to do? And I remember you saying, I know it sounds hard because you're used to a doctor just telling you what to do.
Right.
Your body is yours. And based on what I see, the risks are low enough where if you choose to have a baby vaginally, you can.
Right.
And if you don't want to have that, if you want an epidural, we'll support you. If you want a family-centered cesarean, we'll support you.
Right.
If you want a vaginal birth, we'll support you. But if something goes wrong, we're going to monitor you closely.
Right.
And I tell you need a C-section, you need one. Until then, the choice is yours.
Right.
And it was, and I ended up having my daughter at age 40, at 41 weeks gestation, med-free, vaginally.
Right. Wisdom.
After all of those things. And I felt like I was mentally preparing myself through the whole birth.
Right.
But that would have never happened without you and without your encouragement. And so, I'm curious to know, what is your mission?
Well, I'll try to address the mission question, but some of the things that you outlined allude to that. I can understand how your son was born and the parameters behind that. And you're right. As I say to mom, you shouldn't have to have a PhD in birth to figure out what's going on. With that said, with your second pregnancy with your daughter, it was a matter of really, from my perspective as a perinatologist, is looking at the science behind what your choices would look like. And as you said, I don't necessarily encourage one choice over the other, but do weigh out what those scenarios look like and what is the risk that may be affiliated with one or the other. Especially in the light of VBAC, or vaginal birth after cesarean, where various bodies like the American College of OBGYN and these national organizations support attempting a vaginal birth after having 1 or 2 previous cesareans, of which you fell into that category. The myomectomy removal of a fibroid, that's a separate issue that can be addressed by looking at the operative note. So it truly was one of saying, well, let's look at this, the clinical picture and the science, and see where you want to land with some of this. Not to say that you had to do a dare and I'm going to have a vaginal birth no matter what, but based on the information as discussed with you, as opposed to telling you that this is what you should do, that's the shared decision-making piece that I kind of live in automatically. I see many mothers who come not really understanding that they're having a conversation about choices. And they may say, well, is he serious?
That's right.
It happened so often, Allison, is interesting. It happened Sunday, in fact, where a mom had a beautiful birth plan, but it wasn't being listened to when she was at another practice at a different hospital. And she just felt something was uncomfortable with that. Like, why can't we have a conversation about this? And she switched practices because I think she heard that we have conversations. We talk about things. It was her first pregnancy. And there were some basic things on there about whether she should be monitored in labor or not. Can she take in some nutrition? Does she have to be induced versus not? There was minimal conversation she was getting from that particular group she was with. And we just had conversations about her preferences. And she ended up having a beautiful vaginal birth yesterday, but just wanted to see what the options look like. And she wasn't getting any of that. So having said that, to answer your question about the mission, I've really come to, I guess recently, probably within the past year, and you may have gotten a sense of that when we saw each other in the office a little while back, that no matter how much, at least in my particular practice, no matter how much I have conversations about choices and options and science and obstetrics and maternity care, there are many moms or families that aren't privy to that kind of conversation.
Yes.
So our goal now with my current practice is to really develop some kind of application that allows mothers or families to really have a more balanced discussion in the time in which those discussions are occurring.
And what does that mean?
That means having some tools in your toolkit beyond knowing what in the case of VBAC, beyond knowing what the complication rates are, beyond knowing whether you should receive antibiotics or not, beyond knowing whether you should come in spontaneous labor or not go past a certain date. What does that look like when you truly are having a conversation with a healthcare provider? Despite that information being universally accessible to people, it still tends to be swayed by the preferences of the provider. So the most informed mother is paralyzed, not only with her decision making, but with her voice.
That's exactly how I felt with my first. Yeah.
Absolutely correct. And so in seeing it and having people call me all the time, long distance or not, could you please talk to my doctor? Could you please tell them that what I'm asking for is not unreasonable? Something as simple as delayed cord pulsation for 30 seconds even. I mean, very simple things are challenged, but yet there is a lot of information on websites and various organizations and in certain forums supporting a lot of what is reasonable. So I've just come to the realization that unless the mother has the ability to navigate a conversation with a provider, I'm talking obstetrician and or midwife, nurse practitioner, then she's really at a disadvantage with how that conversation is going to flow because it tends to be based on what the provider's preferences are. So our goal now, my goal is to use information technology, decision making, neural networks, artificial intelligence even to really develop a real-time platform or mobile app, if you will, that allows the mother to really have a conversation that balances itself out based on real information versus the provider's preference.
That's amazing. I just saw this today. I don't know if you happen to see it. I imagine you didn't. You've been doing births and things like that. Right. Serena Williams, as you know, she's been in the news, and Mark Cuban have just invested $3 million in an upcoming startup company, an app called Mommy, Mahmee.
Okay.
And it's an incredible platform that gives provider or gives a patient instant real-time access to providers.
Right.
So it's almost like a real-time thing. So I think they pay a subscription. So it helps them for their first year and say, here's what's going on. And it's HIPAA compliant and it has all of these things.
Right.
But there's more. Yeah, there's more focus on getting mothers better care because I think about this, that after the baby's born, they say it's like a wrapper, like a candy wrapper. That once the candy comes out, the wrapper gets thrown away, And so having that support, not only leading up to either getting pregnant if they're looking for help from fertility, to the gestation, to the birth, and to postpartum, it's hard to find the right care. What are some questions that patients can ask their providers that help them advocate for themselves? What are some good questions? Because, like with my first doctor, I was with her. She was my OBGYN for 12 years. She was a woman. She delivers babies left and right at Northside Hospital, the baby capital, the baby factory. And my friends had gone to her. How could I have not trusted her? But you don't know a provider until something goes wrong. And something went wrong, and I was disappointed and ended up leaving. So how do you ask the right questions? What are the right questions to ask?
Well, I mean, that's a multi-pronged statement. It has a lot of things I do want to address in it. I'm going to go, and I will get to the last part of that as well.
Take your time. This is a conversation.
Great. I want to go to the platform of having the ability to ask your provider a question. So if you feel inhibited by that, or you feel you can't get in touch with them, or you feel that, well, maybe my symptom is not real, it's in my head, then you kind of own it without even letting somebody know that there's a problem. So when you talk about mortality rates and morbidity rates, my understanding, a lot of it is the delay in actually doing something. When you talk about hypertensive disease after birth, or the complications associated with diabetes, or hemorrhage, when you are a patient, you may be reaching out to a mid-level nurse provider. You may call the office and leave a message. You may say, let me wait till Monday, if it's Saturday, to go into the urgent care center. So I think what's become stifling now, and with that an increase in morbidity, is the reluctance for the patient to engage the healthcare system. They don't want to bother anybody. I may be annoying someone. Maybe I didn't have a copay I made last visit, so let me not call them.
That's a really important point, because I would feel that way too.
It becomes delay, really. When you look at morbidities or complications after birth, these issues of hypertensive disease, or in the case of Serena Williams, chest pain and shortness of breath, who's going to act on it? Should I call my doctor 20 times or call my nurse once? And to get pushed to the side maybe a little bit. Or no, that's normal. That's regular. So on the side of the client, customer, patient, there is, I think, more of a reluctance to say, listen, I need help. I'm reaching out for something. So I think that impacts mortality and morbidity rates, in all fairness.
And that's kind of an own personal intuition too, right?
Right. It's like, well, I don't want to bother anybody, so I may not say anything. Having said that, I think empowering the client, customer, patient to ask the question is where things need to be. Because there's a lot of resources out there. But is the person going to ask the question? You may not know what any of the symptoms are for having a pulmonary embolus, but you had some reflux during pregnancy. It may be the same thing, but you're not pregnant anymore. So why is your chest hurting? How about, I'm having a hard time breathing. I delivered a baby. I should have an easier time breathing. So just things that are causing you to ask a question of, is this normal, should be the tipping point. It shouldn't be you trying to figure out whether you are fully into the throes of some kind of complicated process to say, listen, I have a question. I need to have this addressed. I'm not trying to annoy anybody, but giving her, in the case of maternity, the courage to raise her hand, to say, listen, something is not right here. Because when I read story after story after story of moms who were in hospitals and expired, it's usually delay of care.
And that's what happened with Serena Williams too.
Right. Delay of care. Judge Kira
Johnson. Kira Johnson too.
Yeah. People exsanguinating over 12 hours. We have the most sophisticated healthcare system in the world, but now the reluctance to engage it, to say, listen, there's a problem here. Let's address this. So it peels back to what I'm trying to develop or implement, is putting the tools in the mother's hands to say, I have some concerns. They may, I think they're real, But now how do we address them? And I'll probably speak a little bit more about the multi-layeredness of what that looks like.
Yeah. So advocating for yourself, I think, is such a huge thing that I don't know that mothers know, because pregnancy is so common,
Right.
in those cases that they feel, just like you said, that probably nothing, I'll just wait and see if it gets worse.
Right.
Which is kind of,
You're kind of counterintuitive because
it is kind of counterintuitive.
I mean, I'll tell you something though. This program, if you can imagine, I'll give you an example. MapQuest, Google Maps, all those navigation systems, when they first were developed and they first were being used, there was some hesitancy to follow a computer's direction to take you to a place that you were probably familiar with, but it told you to go in the opposite direction. When you did follow the directions of, say, MapQuest, and it took you to the place you needed to be, you realize, oh, I've been going the wrong way all this time. I thought it was make a left turn down here, but it really is make a right. So you then become confident in MapQuest to the point now I think most people will just say, give me the address and I'll follow the directions of what this computer is telling me. Imagine that in maternity care. So here you are sitting in a provider's office. They're telling you there may be a little extra fluid around the baby. Your baby may be big. You have had a previous myomectomy. I think you should be induced early because something may go wrong. This MapQuest-like device will say, extra fluid, previous myomectomy, 36 weeks. What does the data say about that? And then gives you some scenarios to consider.
Ooh, that's so great. So it's like an interactive experience.
If you are 40 years old or you're 16 years old, if you have a certain BMI versus not, do you have high blood pressure or not? Do you live in Atlanta or do you live in Seattle? So really taking that data, big data, and having the ability to say, well, Dr. X or midwife Y, you're suggesting I do this, but based on what this scenario is, these are 4 other choices. Why don't we talk about all of them, your preference and the choices that are here? But I'm now in the space having that conversation with you.
Wow.
So my brain is connected to my mouth. You're not intimidated by me. I'm using big data, published information, and you're using your work experience and what you're training, what you've seen and what you recommend. How do we marry this conversation so that we have shared decision making?
Wow.
And
that's powerful.
Well, not only that, it doesn't
When's that coming out, Dr. Bootstaylor?
It doesn't I'll tell you, it doesn't put the provider at risk who always say, well, I'm worried about litigation. Right. I'm sharing in this decision making and I am choosing options that may be one of yours, in fact.
Wow. That's amazing.
So
I want to congratulate you on being voted Atlanta's top doctor for the 9th year in a row.
Thank you.
And as you know, you have a devout following of people, myself included, that you have greatly impacted my life, my daughter's life, my home life.
Thank you.
I would go out on a limb and say part of the reason I'm here behind this microphone is that having the birth like I did with you gave my voice back. Because I felt like it was taken away when I had my C-section.
Right.
I'm curious that you have a lot of huge fans, and there are a lot of people that are critical of you as well. Right. There are only 2 doctors in Atlanta that openly support vaginal birth after cesarean as a practice.
Right.
So I wonder
It's crazy.
It is, but the fork, I know, like birth is so weird, but the fork in the road where you could have gone the common path, or you could have continuously gone against the grain, which is what you do, and that's why people come from all over the world, in some cases in other states, to be under your care. What did that fork look like to you? How did you choose this? It's a hard path.
You're right. It's hard to continue down the road. But when you look at the road you're going down, you realize that it's the right thing to actually do. The simplicity of it is that there's science to support the choices that are being put before mothers and families. I just find it kind of a little ridiculous that providers aren't supporting the choices. So it's not difficult for me to look at something, use science, weigh out the pros and cons of that, and present that to a family or to a mother. So it's simple to support. It really is. When I go down this road, yes, I have my critics out there, but they can't question the science. They may say, I don't think a mother should have a vaginal birth after a cesarean, but the science suggests otherwise. and you see that with various other things in maternity care. I'll give you for instance. Group beta strep is a bacterial culture that's done around 36 weeks of pregnancy. There is a recommendation to screen for that by the American Academy of Pediatrics and the American Board of OBGYN and the CDC. And people screen for it. Not a problem. There's also a recommendation for treating GBS in pregnancy to reduce the risk of an infection. But that risk is about 1 in 1,000. No one says not to screen or treat. But some mothers are choosing not to treat, even though they may have screened positive, because they understand the benefits of the other bacteria that may be helpful for their baby. And yes, treating GBS, if there's a group B strep infection, is good to do, but the chances of that happening are very, very low. So mothers are making choices whether to treat or not treat. Some mothers are made to feel very, very bad about about choosing the option of not treating. But when you look at the science, it says the risk of infection is less than 1 in 1,000. There are some benefits to the other bacteria that the antibiotics would get rid of. And those mothers are making those choices. So I find it pretty straightforward to support what she understands based on the science and the responsibility she has to her choice. And other providers find that difficult to have those conversations.
Well, I think I'm wondering how much of it, I imagine that doctors go into the profession not just to make money because they care about people, but there's so much incentive to be on a schedule. It's hard to not be on a schedule and be on call for 24/7 and supporting them. So I can see why it would be easy, but it's become commonplace. In 1970, the C-section rates in the U.S. were 10%.
Right.
Now it's over 31%. And in Georgia, it's even higher. Right. What's changed in 40 years?
Well, some of the things you spoke about, the scheduling of things. There's this feeling that if you put it in a box, it's going to stay in the box. And with obstetrics, it's actually kind of the opposite. With that, trying to chaperone processes and make things occur the way you want to occur, you got to start doing things to make that happen. Hence, inducing people at 39 weeks with this new ARRIVE study that came out last October.
What is that? What is
it's called the ARRIVE study?
What does that mean?
It was a study looking at the risk of increased complications with elective inductions now beginning at 39 weeks versus awaiting spontaneous labor. And they were looking at C-section rates, and they felt that the C-section rate was acceptably high enough in electively inducing somebody who has unfavorable for induction at 39 weeks in a blanket fashion. So now I get calls from moms saying, please tell my doctor not to induce me at 39 weeks, when before it was probably 41 weeks, allowing your body a chance to go into labor. But this new study has come out and it's been used as kind of like a battering ram to get moms to be induced at 39 weeks. But the quality of the induction, the type of induction, the provider's patience in that induction will, I'm sure, play into whether those inductions will lead to vaginal births or not. So I suspect there's going to be a higher cesarean rate. So 10% yes in 1970, 31% across the country, and higher in some hospitals is now. But we're going to see higher rates because now the elective induction has been pushed back earlier when the body's less apt to be ready.
That's wild. But I wonder if it is educating the patient a little more and empowering the patient, like you said, that if they have access to more information and they have access to more agency for themselves, for their own care, to advocate for their own care and push the providers to have a better experience. What are some things that you see?
I will tell you that if you go into a certain provider's office and you talk about balanced diet and organic this and eating quinoa and wanting to go to the gym, and some of them will marginalize you. Oh, you're talking about quote unquote natural birth, and they'll start to pull that carpet out from underneath you. You're not gaining enough weight. We need to do this screen for this. And I think we need to have the baby early. It's kind of on the small side.
Do you think it's like the panic buttons hit too early in a lot of cases?
Absolutely.
Yeah.
And they're hit to help with the schedule. If I have people making choices and following science, then there's going to be this kind of scattergram of when things occur. Well, let me just induce everybody at 40 weeks. If they have a C-section, so what? They got a healthy baby and they're alive, right? Versus, well, what was it really necessary? Oh, there was the practice's philosophy to induce everybody early. C-section or vaginal is not the end game with this. It's the process. Cesareans are very helpful and necessary. Vaginal birth is wonderful, but it's the process and how those occur. You can have a very, torturous induction of labor that was because the provider felt you should be induced, and have an unhealthy process and it had a vaginal birth. So what's lost in a lot of this is actually the process, not necessarily how the birth occurs.
Can you explain the family-centered cesarean? Because I didn't know what that meant until I came to you. I didn't know it existed.
Right. Be happy to. I just did one about an hour ago. It's one where we try to use certain language so that a mother can get a sense that she's having a birth. We use family-centered in that, wow, it's not just you yourself alone with this operating team, the OBGYN, nursing staff. So family-centered, the language itself just kind of takes it out of this realm of, I'm going to have this sterile surgical procedure. So that in of itself is essential, I think. But the mechanics of family-centered, we call it surgical birth, but family-centered cesarean is one where we'll walk a mom to the operating room. She walks there. Typically a spinal anesthetic is placed. And then on the operating table, I myself will collect something called microbiome, which is the vaginal secretions from the birth canal, which has good bacteria in there, which can help the baby's gut flora after it's born. So there's an inoculation that can occur in the recovery room. And there's science supporting that. There's a lot of PhD work, by the way, looking at microbiome and inoculation of the baby. So I'll collect microbiome inoculation so the mother at least knows the baby's getting some of that good bacteria. We will not restrain a mom's arms. Her hands are free. Her birth partner is sitting at the head of the table with her. He or she can take pictures. They can roll video. With the birth itself, we do delayed cord clamping. So there's pulsation of the cord, and which kind of mimics a vaginal birth. And then after the baby is examined by the pediatric team, which takes about 5 minutes, the baby's brought back to the mother and placed on her chest for immediate skin to skin. And they can do breastfeeding, latching on. Oftentimes there's a lot of warmth and energy and hugs and holds at that moment. And the baby stays with the mother and the birth partner throughout the surgery. And it's only when we transfer to the recovery room does the partner go with the baby so we can take mom to the recovery room separately. It happens about maybe 5 minutes apart. And in the recovery room, like I mentioned earlier, I do the microbiome inoculation of the baby, and they continue with their bonding. And so it's a family process as opposed to having a C-section.
Yeah. I remember watching, you had a video explaining that on your website, and I remember crying when I was pregnant, going, oh my goodness, why didn't I have that? That sounded so beautiful, given the choices.
Right. But I'll tell you though, the piece in all of that I just described, the critical piece that I get phone calls about is the skin to skin. If there's certain policies in that particular patient's hospital, they want the hands tied down. They don't want you collecting microbiome for what that's worth or doing certain things. The least the obstetrician could do is let the mother have the baby on her skin to skin. And that's not adjusting any anesthesia policies or changing the dynamics of the surgery or compromising the quote unquote sterile field. It's really taking this baby that this mother has waited 10 months for and allowing her to form that bond and to begin their journey. So out of that family-centered piece, a mother should be able to ask their obstetrician, can I do skin to skin in the operating room? If we're going to have a C-section, agree with it. I'm glad we're doing it. I'm glad you even scheduled it. But can I have skin to skin in the operating room? And the simple answer should be yes. And that's where mom's voice needs to direct that provider to facilitate that small but significant request.
That's beautiful. And I remember when I had my daughter, and as I said, it was vaginal, it was med-free. And after I had her, it was so different from when I had my C-section because I was tied up. And I remember shaking because I had so many drugs in me, from all of the birth drugs. And I was like, I had thrown up before because I was so upset over the decision. And I remember shaking, and then the baby was out and they came over and said, kiss your baby. We're going to go clean him up. And I didn't see him for hours. I didn't know where he went, and I think it might have been who knows if it was just kind of a fluke that had happened. It was around Christmas. So I think it was a lot of babies were being born. But conversely, with my second, my daughter Juliana came out and put her right on my chest. And I don't think they cleaned her for 3 hours.
Right. Exactly.
I don't even think the cord was cut for that long. And she just stayed there immediately. It was just beautiful. It was so healing. And I remember my girlfriend, Isabel Dupree, who, as you know, is the one who introduced me to you. And I remember when we were both pregnant with our second. Right. And I remember we were at Flywheel and it was like 6 a.m. And I was, really trying to think about what kind of birth I wanted. Could I have it? Am I being too risky by thinking of having a vaginal birth after so many doctors told me not to? Right. And she had a water birth with her first, and it was, med-free vaginal. Right. And she said it was the most empowering thing she ever did. And it was Flywheel, so it was like a spin class. Right. And I remember being so pissed off. And I remember pedaling and thinking, I'm so pissed. I'm so pissed that was taken away from me. Yeah. And the only reason I say that was taken away from me is because what I learned with my second pregnancy, I had the same complications the second time than I did with my first time, but was at a higher risk. Right. And was able to have this successful, beautiful, healing birth. And I remember her saying, like I said, it was the most empowering thing she did. Oh, it's changed my life. Like there were things that I don't know that I would have known I could do, but felt like I could. And so for that, I'm forever grateful for you.
No, well, thank you
for giving me that option. But and I was trying to get through this interview without crying because it is a visceral experience for me. But
I'm the trajectory.
It really does change the trajectory, but I'm wondering, what are some good questions aside from just having that conversation? What are some good questions to ask? What are some common things people come to you with maybe misconceptions of that you can help clear up?
I'll answer that by saying I speak to the most well-informed, knowledgeable, passionate moms about their experiences they may have had some other place. And they get paralyzed in those conversations. So it almost starts with the environment you're in to have the conversation.
How do we get the power back? How do we give these moms the power back?
If something is in your hand that you believe in, and it has to be a physical device that you feel it, because you've read VBAC facts, you've spoken to your friends about eating in labor, you have a cousin who's an obstetrician in California, you have knowledge at your fingertips. But in the moment, your voice cannot connect to your mouth. You're paralyzed. Why? Because you're vulnerable. There is a baby that you need to protect no matter what. So if that provider is saying certain things, you almost can't process what the answer is. Because that's that maternal instinct that's been developed over who knows how many millennia for you to protect that baby against your total understanding of what it should be. You are not going to tell a provider, put the brakes on that. Very few moms could do that. So that's why when you ask what questions they should ask, what references they should take, it almost has to be, here's my superpower to be able to make this a level conversation. I'm trying to have a conversation with you about the science and what I think what my preferences are. So I tell people what the questions they should ask, what they should consider, but it's hard if that provider is going to shut it down and guide you in a certain way. It's very hard. So I truly feel after all these years, because when people talk to me, in all fairness, it's a conversation about all of this stuff, and they can speak, they can ask questions. They walk out the door. Should I try this? Let me ask him again. Let me have a separate consultation visit to make sure he's saying what I heard. But I don't try to make the conversation one-sided. I really make it a dynamic so that your insecurities, your uncertainties, and ignorance could be addressed, and you feel confident in what's being shared. So I'll describe for you something briefly. I wrote something out maybe about 7-8 years ago called the Provider App. The Provider App was 10 questions that a mother could ask their provider to see how this birth journey was going to be, the prenatal visits, and even the labor, if you will. And there were certain questions like, will the provider treat me like an adult? Will they have a conversation with me about birth options that they may not even support, but yet can have that conversation, such as, getting in the shower during labor, or walking around the hallway with intermittent monitoring. Those are very low entry level, labor options. So this provider app was 10 questions. They were very fundamental, but it was to give you a sense of, is this the right office for me? So thereby, if you can at least get the right provider in your app, in your stratosphere, then possibly making the choices that you want, be it things that are of a higher magnitude, like vaginal birth after cesarean, going over your due date, ambulating in labor, walking, eating, then the providers you're with, or at least are going to be having that conversation with you. And so the provider app was to screen out who was going to be in your stratosphere for this pregnancy. So at least you're not having that battle.
Is that still around? I can link it in the show notes.
Yeah. I'll send it to you.
Yeah. And I'm thinking about the essentials. There are a lot of questions that moms have.
Right.
Do I need a doula? Do I need a midwife? Water birth? What are the benefits? So can you talk through some of those things of like midwife or no midwife, doula versus no doula?
Sure.
Tell us about the benefits of some of the questions, even glucose tests. What happens if I fail? Am I going to have gestational diabetes, or what are some ways to combat that? Or any guidance on making pregnancy easier, of some of the benefits of things that might be available?
Regarding the midwife versus obstetrician versus others, if you will, it's the ability to have conversations about choices. Midwives support birth options and choices, whereas obstetricians tend to have some protocols that they're comfortable with, things they have trained in and they're comfortable with, and thereby the philosophy of the practice kind of goes in that direction. Midwives are about supporting options. The challenge, though, for some midwives is that they may be with some providers, obstetricians, who may not be fond of those options or willing to support those. So they're little handcuffs oftentimes. Having said that, someone to help a mom massage those choices is a doula, to kind of tease out from you, what are you thinking about, how things may look for you? Is it really the right environment to be in? Not making medical judgments or giving medical direction, but really trying to get out from that mother and family, if you will, the partners. What are they anticipating regarding this pregnancy and birth? So those three individuals, there hopefully is some, alignment, if you will. But one has to be able to have conversations with the obstetrician, midwife, and or doula, and be able to find their voice and raise their hand and ask questions. So they're very helpful, but when you don't have your voice and they're shutting it down literally by making you feel guilty to ask a question, you may not want to even talk about some things anymore. You may say it's best to be quiet. Let me just get through this pregnancy and hopefully I get out at the other end intact and healthy baby. So you have to say to yourself, who am I surrounding myself with? Doulas are very helpful, especially during labor. They help with labor support and helping to remind you of what things you can do to make it better. They help birth partners and families, by the way.
They were big help to my husband.
Yeah. Highly endorse them. As a matter of fact, at C-Baby, we had a doula consortium at one point because we were so fond of that tool for a mom to have during the course of pregnancy and labor. Just to skip the glucose test so I don't forget, because that's an important one. There are different ways to screen for that. About 10% of pregnancies are affected by some glucose abnormalities, and a glucose screening test helps discern who is at risk for that. If you can either do glucose paneling, stay on your regular diet, check your finger sticks 5 times a day for about 1 to 2 weeks. If your glucose is high, you probably need to be on a diet and or do the glucose test. But the quickest way to get through that is to take a glucose test, but it could make you kind of nauseous sometimes. Some moms can't complete it, but there are cutoffs for that. But one just has to be mindful of the fact that about 10% of pregnancies are complicated by some kind of glucose metabolism, gestational diabetes. And then how do you manage that? Which means that even if you do get diagnosed with gestational diabetes, you can still have a kind of a medicated free pregnancy, or you're just on a diet, you're checking your glucoses. Is when those things are hard to manage, or then you go into other things like oral hypoglycemic agents and insulin and things like that. So the entry point doesn't have to be a big barrier. You can just have a glucose paneling of your regular diet to see how that looks.
What about trying to make labor happen? When people are at Scalini's, I think that place closed for their eggplant parm, but
there's a Nobel Prize in there somewhere. I can tell you
what are some good ways to kind of induce labor naturally?
mean, I hear it all, I must admit. People come with a laundry list. What else can I do after these 15 things? So it's nice, fun conversation in the office, I must admit. But it really is waiting for time to go by. And what happens with maternity care is that there's so much pressure to schedule, if you will, from family, friends, people texting you, your own kind of understanding of maybe something is going to go wrong. Maybe I should do something earlier. So there's a lot of that pressure to bear. So you look for ways to naturally induce, eating pineapple and eggplant parmesan and blue cohosh and evening primrose and yoga, acupressure. But
you're just walking around.
Walking around, if you can walk, if you're not. The list is long.
The birth ball.
The birth
Does
ball.
the birth ball
moving.
work?
Of course it does, but it may be coincidental.
Yeah.
You have cervical massage, membrane sweeps.
What is cervical massage?
Where you try to dilate the cervix manually with a digital exam. And that
sounds gross.
It is uncomfortable. Believe me. I remind moms, it feels like a contraction. So it's like, so people are doing all this. Meanwhile, you just have to be mindful of the baby's well-being, which is usually through kick counts. And if you're being monitored with ultrasound, looking at fluid and blood flow, but actually waiting for time to go by. But imagine if you're moving up inductions to 39 weeks, you could potentially go to 42 weeks. So if you're 40 weeks and you're beyond a certain date, then you start trying to find things to induce, and then you bring a certain level of energy to that. But truly, it really is. There's a little plaque in my bookcase in the office. It says tincture of time on there. And I'm constantly pointing to it throughout the day to moms. What should I do? It just takes a little time. The baby is moving. You're fine. Your blood pressure's fine. But you do bring all this pressure to bear. You speak about schedules from earlier in this conversation. Yeah. So do nothing. I tell people a lot.
Do nothing.
Yeah.
What is the oldest mom that you've delivered?
Funny you asked that. There was a mom about maybe 5-6 months ago. She was 52 years old.
Oh my goodness.
Yeah, frozen embryo. She had her first baby at 48. Frozen embryo also, by the way. But so yeah, she was 52.
Wait, how old is Janet Jackson? Didn't she have a baby
at
50 something?
51, yeah.
Unbelievable.
Yeah.
Do you think that was frozen embryo for her too?
I suspect.
Yeah.
I suspect. Glad she was able to get through that though.
Wow.
Yeah.
Are you finding that women are coming to you older? Like, are you seeing any trends from the moms that come to you?
And I say with wisdom, so we all can laugh about it.
I'm an older mom. I had my first at 38 and my second at 40.
Yeah, you have wisdom.
Yes.
And that's the words come out of my mouth so easily. And I think, wow, I'm glad you said that. Because everybody says I'm, what they call it, a geriatric pregnancy. That's definitely flattering. But
not at all.
There is a trend for moms to be a little bit older, over 35. So it's about 10-15%.
Wow, that's amazing. Yeah. Mm-hmm. So what's next? Aside from the app, what's next for you?
Well, I mean, that's the fun piece, to be honest, because I gave a conference recently.
That sounds culture changing, Dr. Bootstaylor. Truly.
Well, it's going to put the customer in the driver's seat to make the people who are providing the service better. Mm. So if a lot of customers can raise their hand and speak their voice, then the provider's going to be a little bit more astute and probably adhering to the science more so than their preferences of what they want to see this mother's pregnancy, how they want to see it unfold. So that's where a lot of my energy is going, mainly because of all of this experience I have and the things that I can support. But this is based on science, really. It's not my personal preference to do things. It's looking at what has been shown and studied and allowing a mother to be part of that conversation.
Well, I could see how the AI could help too, kind of
absolutely
build pathways or algorithms based on, all those points that are going to kind of point them in a different direction. I think it's a brilliant idea.
And if you're if you're sitting in that office or in that labor suite and you're trying to answer the question that's being posed to you, like, should I induce or should I not induce? Is it your practice's preferences or is there science associated with this? And if it's your practice's preferences, I can understand and respect that. Can we talk about that? If it's science, thank you. Algorithm, AI ran through that. Can we talk about that? And I'm not talking about 40-minute conversations about whether to take vitamins. It could really be 2 or 3 minutes of acknowledging something and allowing that mother to be part of the process.
I love it.
You would be amazed at what that will do for a mom's experience.
I know it by experience. How can people get in touch with you?
Good question. Our website, cbaby.org. See like you see something, SEEBABY.org.
Where did that name come from?
I do ultrasound also as a perinatologist, maternal fetal medicine specialist, and I'm looking at babies all the time on ultrasound.
So you're always seeing babies.
I'm seeing babies, but also seeing moms take it from a point of mystery to seeing their baby on a screen, and now all is right with the world. And so they see that and they say, oh, despite all the rumors, and I was told the baby was too big, and I was told I could never do this, and I was told, once I see the baby, I realize what I can do. So that's where the name came from.
Is it true that the weight of a baby, projected weight, is not necessarily the indicator? It's the size of the head on whether it can come down the canal. Do you understand what I'm asking?
I think so.
Like as people will say, if you have a 10-pound baby, you know, like somebody told me, and I don't know if this is an old wives' tale, so I'll ask if it's fact or fiction, but somebody told me to drink like Chick-fil-A shakes, like milkshakes at the end of the pregnancy. To beef up the baby because they will sleep better when they're on the outside. Wow. And that, it sounds like this is complete bullshit, but
I may have to bring this to the office tomorrow. No.
But it's not necessarily that you have a huge baby and that makes it more uncomfortable. It's just the size of the head is really what makes the, coming down the birth canal very uncomfortable. Well,
I mean, I think that's an interesting vignette, if you will, and I'll keep it in mind. But it truly is, I mean, a lot of factors from one, the pelvis needing to be molded, tissue that hasn't been stretched, now being stretched. Just pulling your ear one good hard time, you feel how much that hurts. Imagine changing the pelvis. So the passenger does impact on that. The mother I mentioned who I had a birth with yesterday, she skewered all over the place from what was going to be an unmedicated birth to an epidural, and her baby was 6 pounds. So it wasn't the size of the baby. There was some things that needed to change with her, but also her appreciation of what discomfort is and her tolerance for it. So I think it's interesting to try to fatten up a baby the last few weeks of pregnancy, only to
so they can sleep later,
have good sleep patterns.
You probably hear the craziest stuff too.
That's a good one though.
Yeah, you're welcome. Well, thank you, Dr. Bootstaylor. Is there anything else that you'd like to mention before we sign off?
Well, I want to thank you, Allison, for having me be a part of your podcast. I was excited to hear you were launching it. It was great to be here today, and thank you for allowing me to care for you during your last pregnancy.
I am honored to have you here. Thank you so much, Dr. Bootstaylor. You're a culture changer.
Thank you. Thank you.
I hope you enjoyed my chat with Dr. Bootstaylor. I can't wait for his app to be available to the public. I've linked his information as well as the provider questions in the show notes if you'd like to learn more. And if you think this episode could be interesting to people you know, share it up. Please consider also writing a review on Apple Podcasts or wherever you listen. I read every word. As always, thank you for listening, and I'll see you next week.